Hello, I'm Bertrand GACHON from Poitiers Hospital in France. I thank the ICS committee for the opportunity to present this work entitled Impact of National Guidelines for Restrictive Use of Episiotomy on Obstetric Anal Sphincter Injury Occurrence during Instrumental Delivery, a national multicenter historical cohort. As you know, the most important risk factor reported for obstetric anal sphincter injury occurrence is operative vaginal delivery. There are some retrospective studies suggesting that mediolateral episiotomy could be protective from obstetric anal sphincter injury, but there are no high level of evidence studies explaining the absence of strong guidelines in favor of episiotomy. In 2005, French guidelines recommended a restrictive use of episiotomy for all deliveries, including for operative vaginal deliveries. Our main objective was to assess the influence of these guidelines on the episiotomy rate during instrumental delivery in cases recorded into the AUDIPOG French database. Secondary objective was to assess the influence of these guidelines on the rate of obstetric anal sphincter injury during instrumental delivery and the episiotomy rate according to the type of instrument used for the delivery. It was a multicentric historical cohort involving almost 200 maternity units between 2000 and 2016. We included operative vaginal delivery about fetus in a cephalic presentation at 34 weeks of gestation or more. The study period was divided into 3 phases. The first one was immediately before the publication of the guidelines, 2000-2005, which was the reference period. The 2 other periods were immediately after the publication of the guidelines, 2006-2011, and the last period was 2012-2016. We first described our population and the crude rates of episiotomy and anal sphincter injuries across the time. Then we reported adjusted relative risk of episiotomy and obstetric anal sphincter injury occurrence in multivariate analysis by controlling confounding factors. And last, we investigated for change in episiotomy and obstetric anal sphincter injury rates across the time using a Press-Wheaton regression in order, once again, to control confounding factors for both anal sphincter injury occurrence and episiotomy use. First part of the results, you can see that we included 96,035 deliveries. It is interesting to note that the proportion of nulliparous women significantly decreased across the time, as well as the proportion of neonates with a large birth weight. The other point is that the use of forceps significantly and drastically decreased across the time, whereas the use of vacuum significantly increased during the same period. All these changes are expected to be associated with a decrease in the risk of obstetric anal sphincter injury. In this first figure, you can see that the rate of episiotomy, the crude rate of episiotomy, significantly decreased after the publication of the guidelines for all subgroups, whatever was the parity and the type of instrument used for the delivery. During the same period, you can see that the crude rate of anal sphincter injury appears to be increased across the time, with the most important effect in the forceps group. In this table, you can see that the relative risk of episiotomy significantly decreased after the publication of the guidelines. The first line here represents the comparison between the first and the second period. The second line here represents the comparison between the first and the last period. The relative risk of anal sphincter injury significantly increased after the publication of the guidelines. It is interesting to note that in a subgroup analysis according to the type of instrument used for the delivery, the increase into the relative risk of anal sphincter injury only became significant when comparing the period before the publication of the guidelines and the last period, meaning when the rate of episiotomy was the lowest. In this last figure, you can see that pre-Winston regression allows to report a significant decrease in episiotomy rate across the time, whereas the increase in obstetric anal sphincter injury rates did not reach statistical significance. So in conclusion, the association between episiotomy and obstetric anal sphincter injury during operative vaginal delivery is still conflicting. Even if it seems to exist an increase in obstetric anal sphincter injury occurrence, meanwhile a significant decrease in episiotomy rate, the multivariate analysis in our study failed to report such an association. We could hypothesize that with a more important decrease in episiotomy rate, the increase in obstetric anal sphincter injury occurrence would have been significant, and this would have been consistent with the literature and with our subgroup analysis according to the type of instrument used for the delivery. Finally, large prospective studies are still required to provide clear guidelines and to identify situations where episiotomy is required during an operative delivery to avoid anal sphincter injury. There is an ongoing study in France, which is the Instrumoda study involving 15,000 nulliparous women, and I hope that I will be able to present you the results of this study in an upcoming ICS Congress. I really thank you for your attention, and I will be happy to answer any question. Thank you.